Ο επόμενος ομιλητής είναι ο κύριος Αναστασάκης. Θα μας μιλήσει για την μυοκαρδίτη.
Είπαμε να ακολουθήσουμε τη σειρά.
Εντάξει, οκ.
Λοιπόν, είναι ο κύριος Αναστασάκης, θα μας μιλήσει για την μυοκαρδίτιδα σαν πρώτη εκδήλωση αρρυθμιογόνου μυοκαρδιοπάθειας και περιμένουμε να σας ακούσουμε, Άρη, με μεγάλο ενδιαφέρον.
In English.
Ό,τι θέλεις.
In English.
Είσαι ελεύθερος.
Okay, I will try my best. So, Andre Keren, an authority in a field and a very good friend, created the base, a solid base for me to stand up and present to you our experience in Greece. I will present some cases that we face in the National Health Service and in Anastasakis Center, and we'll check our practice, if it's consistent with the guidelines or not. So, there was a young female, 31 years old, with chest pain, ST elevation, elevated cardiac enzymes, coronary angiography normal, and an ejection fraction preserved. Here is the ECG. You see the ST elevations in the inferior leads. You see the troponin, the coronary angiography, which was normal, low voltage, ventricular ectopics from the left ventricle, right ventricle, subepicardial fibrosis. So, is this a typical myocarditis? Yes, we have clinical indication that this is a typical myocarditis or a post-myocarditis case. But if we go back and try to make a full examination of this patient, and we go back to the medical history, she's a young woman where some years ago, before that event that I just described to you, he had ventricular arrhythmias and pressing-opal episode. The ventricular ectopics were there before the event, and there are monomorphic ventricular ectopics. This is another thing that we have to be careful. From the clinical examination, we realized that she had a significant palmoplantar keratoderma. And when we went to the family, we realized that most of the family relatives had curly hair. And there was also a sudden death of her brother when he was 88 years old, with exactly the same event. And then, 5 years later, he died suddenly. Normal coronary arteries at the time of the event. And so we realized that there was a family case there. So we performed genetic analysis, and the genetic analysis revealed a desmoplakin mutation. Some years ago, later, that has happened in 2011, 2015, we see that here we have an ejection fraction which is about 40%, and segmental dyskinesia and arrhythmias, malignant arrhythmias. That's why we implanted an ICD. So the speculation, because so far we have speculation about that, what myocarditis can do, is that maybe myocarditis triggered a predisposition genetic substrate, a genetic substrate that predisposed to cardiomyopathy. That was the scenario number one. And the second scenario is that desmoplakin itself has a natural history which includes hot phases that they are very close to inflammation, to myocarditis. And at the end, we can have different end points. We can have disease, we can have mild disease, or we can have finally a healing phase, and or the development of DCM or ACM of cardiomyopathy. In this case, we had a mild form of cardiomyopathy with many ventricular arrhythmias, an arrhythmogenic case. So we implanted an ICD, but we have done nothing else. In the case 2, so in the first case actually is that through the extracardiac findings, we realized that we are facing not a myocarditis, but an inherited cardiovascular disease due to desmoplakin. In the second case, we have a woman 32 years old with chest pain, troponemia, low ECG voltages, and preserved ejection fraction, edema and CMR, and we performed their myocardial biopsy with revealed with enhanced infiltration of lymphocytes and a negative PCR results for viruses. You see here how this girl was, as we were following up this woman, young woman, we had the burst of troponin, and when you have this, you have to do something. I mean, you realize that you have a patient that you are looking at him, and you just give him some treatment for heart failure, let's say, but you realize that this is not enough. So in this case, we performed the biopsy, and then we put that lady to immunosuppressive treatment, and we had another burst of troponin, but very fast. Maybe it was not, the measurement was wrong, but we realized that all the arrhythmias and the fibrosis, the troponemia, and the events declined, went down, and still today she's doing quite well with not any recurrences. She took the treatment for about 1 year, for 6 months the steroids, and then he remains on azathioprine for longer. So azathioprine steroids, 2021, then tapering of steroids, then he had also in the family a sudden death of her father, and again in 22 an acute chest pain with elevation of troponin, but for a very brief time, and since then she is asymptomatic. The ECG is typical with low voltages and ventricular arrhythmias, but the CMR, you see that the function is doing quite well. There is, although, fibrosis, circular fibrosis, sickle-like fibrosis, subepicardial in the left ventricle, but the function remains good, and since then, since 2022, she had arrhythmias in the past, and before the treatment we had to put an ICD because we realized that she has also the desmoplakin mutation. So due to the arrhythmias and desmoplakin mutation and fibrosis, we decided to implant an ICD, but on the other hand, we believe that through the treatment of immunosuppressive treatment, we saved the function, the pump. In the family now, you see that there is some evidence of that something was going wrong. There was arrhythmias from her mother's side, sudden death from her father's side. Her mother has a very low voltage ECG, which is not, of course, a very specific sign. And when we performed the genetic analysis, we realized that the mutation was coming from her father, where there was a relative on that side of the family with sudden death. So for us, it's pretty obvious now that when we have, as we say, noise in the family, evidence that something is going on, but not something very typical, for example, like a cardiomyopathy. ventricular arrhythmias in other relatives, maybe troponemia unexplained, sudden death, of course, in the young or in the mean age. There are things that when you pick up from the family history or when you check the family members, you examine the family members, then maybe you realize that in this, in many of those families that their children experience myocarditis, there are other findings in other relatives that could be clinically significant, and they guide us to go and perform genetic analysis. So the full picture of that girl now is that she has an ICD, she has ventricular arrhythmias, she has fibrosis, but the function is good, she's living with a very good quality of life, and she's stable. Of course, if we go to in that stage now, if we go to the criteria, Padua criteria, for example, for ACM, she fulfills the Padua criteria. And as I mentioned, since the time that she got the treatment, she's stable and healthy. Why we gave that treatment? We gave that treatment because exactly the publication that Keren mentioned, 20 years follow-up, and they succeed. I mean, the result of this study was that using the immunosuppressive treatment in myocarditis, they had less cardiovascular deaths, less heart transplantation, less ICD implantation. The recurrences were not always less, but each time they were treating. So that's why they got the other results: cardiovascular death, heart transplantation, and ICD implantation. So maybe this is the practice that in Greece it's very difficult to implement actually. In Onassis, Onassis is a special center, so for us it's quite easy to perform a biopsy. But the problem is that we have to question ourselves how are we dealing with myocarditis in the young people when we don't perform this. Of course, Keren said that we can give treatment blind, but not for a while. Yes, exactly. So when in myocarditis we trace a genetic substrate, this is extremely important because it can influence the management of myocarditis, and of course we can do things for the family of the patient that had the myocarditis, which was due to a genetic predisposition. Of course, in the cases where we have genetic predisposition, as Keren already mentioned, we have more complications. And actually, the genetic substrate like desmoplakin, it's a high-risk substrate. Our experience, we checked families that they had myocarditis, and we checked if they had this noise, as I say, in the other members, and we realized that we had a genetic yield. Of course, we are a referral center, maybe this is biased, but we had a genetic yield of 78%, quite high. And you see also the filament cell, lamin A, titin, PKP2, PLN, desmoplakin are the substrates that are already in the literature, and you know there are similar results with the literature. I will finish just tracing emphasizing in the family how important it is to go for the genetic substrate, not just for the patient but also for the family. Here we had a young girl who died from myocarditis. I don't know if this is convincing, Dr. Shepard, but that was the result from our lab, histopathology lab. 14 years old, athletic, a swimmer. And when we go into the family, we realize that the father, 43 years old, he had this picture before he died. Then he went, he experienced sudden death, which is actually that's something that we call non-dilated LV cardiomyopathy according to the Cardiomyopathy 2023 guidelines, which means a preserved ejection fraction, subepicardial fibrosis, sick line, low voltages, arrhythmias, and a malignant genetic substrate. So that was the father. The father didn't accept this because we checked him straight after the death of her daughter. She refused that this was right. She couldn't accept it. And then he died as well. And of course, there was another sudden death in a generation, in the father's father. And we performed the genetic analysis. It was desmoplakin mutation again. And I think the important part is this, that we managed to follow up one of the girls who was gene positive in that family. And we look how the whole thing has started. We had initially, there was a normal girl with a gene carrier, genotype positive, phenotype negative. And then 50 ventricular ectopes started to appear. And then some years later, from 2012 to 2014, 6,000 ventricular ectopics. And then you see the fibrosis tissue in the left ventricle. And of course, we knew that that was desmoplakin. We saw the evolution. We put an ICD, although there were not guidelines at that time to do so. And then in 2017, we have the discharge of the ICD. And it's very important to see how the evolution is. Normal ECG, ventricular ectopics. Then in 2014, an abnormal ECG with ventricular ectopics. Normal ejection fraction till 2017, and 2019 then the ventricle starts to be impaired, and we have another activation. Okay. Oh, thank you. So, normal ECG, 2012, abnormal ECG, 2014. Initially, the first sign was ventricular ectopics. Then, of course, ejection fraction normal. We knew that it was there was some fibrosis, and then we saw the discharges, and the ECG becomes grossly abnormal. So, what's the message for this? That, okay, we know that usually ventricular ectopics are benign, but sometimes maybe inherited cardiovascular disease can start with this mild phenomenon, which gradually increases. So we have to follow up these people. This is the main message. Does not mean that a young boy that has ventricular ectopics, few ventricular ectopics, you have to ignore him. No, we have to follow up him to be sure and to perform this evaluation to be sure that he is really safe. I think Dr. Papadakis will manage to say about the post-myocarditis cases and how we manage to allow them to in athletic activities or not. Another thing that I want to mention is that from the myocarditis patients, we have also to be very reluctant to say that everything is fine, you are healed, you are fine. You have to follow up them because sometimes, and to continue giving the treatment, because sometimes we have recurrences in a second stage. We can have you know, in the beginning, you have the disease, the myocarditis or DCM cases. Then you can have a reverse remodeling, but this does not stop there. In a second stage, maybe you can have an appearance of the disease of DCM again. So we must be very careful, and we have to follow up these people. Of course, the theories that we have at the moment is that we have some people have a genetic susceptibility, and there are triggers like viral triggers, alcohol triggers, athletic triggers, infection triggers that can activate this genetic substrate, and we can have the disease coming up. So there are, for example, it's very you know, impressive that in families we have people that they are involved in the athletic activities and people that they are not involved in athletic activities with the same genetic substrate, and we have a different remodeling. And we also have to see again all this case of the athletic heart syndrome. So we have an interplay between environmental factor, genetic autoimmunity, and we have red flags which show us which has to go for genetic analysis and who is not necessarily for this. It's not necessary to go for this. And at the end, I think the key question is that, is myocarditis the offending cause which uncovered the myocardial genetic anomalies, or the genetic alteration renders the myocardium prone to myocarditis and its evolution towards DCM or ACM? So it's the chicken and the egg. The take-home message is that there is no indication for performing routinely a genetic test in patients with diagnosis of myocarditis, but genetic testing must be considered, I think, not might, in the presence of clinical red flags that should be carefully and systematically evaluated. Thank you very much.
Ari, thank you for this very nice presentation, also challenging cases, but we have no time for discussion now. And we'll move to the next speaker, who is Professor Manolis Papadakis.